Okay, here's my signal. Good afternoon, everybody. Glad you're joining us again for our weekly web seminar, Innovation in Biotech in the Time of COVID-19. Today, I have an illustrious panel to discuss immunology questions and epidemiology questions around COVID. And I'm glad to welcome Jonathan Grad, who's a professor at the Harvard Chan School of Public Health and also an immunologist by training. And Rick Malley is joining us again, immunologist and infectious disease expert at the Children's Hospital. Thank you both for joining us. So in Massachusetts, the momentous thing that had happened yesterday is that Governor Baker has issued a new set of rules that allow some businesses to reopen, and the Massachusetts government has declared sort of a phased reopening and advised us that they may go back depending on this. What I'd love to understand what your both's view of these measures is. Are they going to be helpful? Are they the right steps? Are they going too far? Are they too far behind? Maybe start with you, Jonathan, since you study populations. What is your view? Is there any advice that you have for the governor and for us?
Thank you, Johannes. I'm glad to be here, and especially fun to be on with Rick as well. So there is huge tension between the, on the one hand, goal of flattening the curve and limiting the amount of disease spread, and doing so through the blunt instrument that we've used so far of community quarantine. And on the other hand, the economic cost that has been so dramatic, and as we have seen, and clearly between this Charybdis and Scylla, the governor and his advisors have to navigate, right? How do we maintain our healthcare infrastructure, right? The main goal of flattening the curve, of course, is to not necessarily prevent all disease, but at least limit the chance that we see what happened in Wuhan or Northern Italy or New York, where it was basically the verging on collapse of the healthcare infrastructure. How do we do that through, again, flattening the curve, while at the same time not causing economic worsening economic crisis or economic devastation, which itself might have health consequences. So with the success that we've seen so far in, we see that hospital census is going down, it certainly makes sense to consider how can we best start to open up and emerge from this blunt instrument of community quarantine. It continues to be a challenge, and I don't think that there is an obvious right answer here, although we know pieces of the puzzle that are necessary. One of them is extensive testing. We need to be able to monitor what is happening in the community. How much disease is there really? Monitoring just who's in the hospital or what our critical care usage is probably too late. Right? We know that there is around a 3-week lag between the emergence of cases and the need for the use of hospital beds and critical care beds. In Wuhan, for example, the city shut down after just, they noticed a few hundred cases, and then even having had that shutdown, 3 weeks later, they were basically at or above what the US critical care capacity was, right? So they're knowing that there's transmission in the community, we really have to monitor that element in order to determine, what our next intervention will be. So I think that it is right that we try to open, but then we need to think about how do we monitor for the burden of disease when we should expect to see a resurgence in virus. I say we should expect it because the virus hasn't gone away, right? It is still transmitting, and it doesn't care what we've done. It just cares if there are susceptible people in a population. To the extent that it can continue to spread, it will. As people start to interact more, we should expect to see more cases. We need to have an ability to monitor that rise in the number of cases and then respond appropriately. What does that mean? Do we have to implement the same kinds of extensive restrictions that we've done now? Hopefully not, but how do we tailor them? I think that is an unanswered question. I haven't seen much in the way of the government plan for improving on, again, this mass community quarantine. If we see resurgence in particular communities, do we try to focus the quarantine on those communities? Are there other efforts, contact tracing, quarantine isolation, that can feed into this? Are there more nuanced or sophisticated approaches to try to slow disease transmission beyond just the community quarantine? I think those are the kinds of questions that we really are going to have to grapple with when we start to see the resurgence. And again, we need the extensive testing in order to really be able to detect it before we again risk the threat to the healthcare infrastructure.
Yeah, so if we wait to see hospitalizations and death rates go up, then we've probably waited too long and we have too blunt an instrument to measure this.
Right. I think if it's not that not just that the instrument is blunt, it's that it's late, right? Yeah. By that point, we would expect there to be sufficient community transmission that we will start to see, again, very large numbers. We want to be able to pick it up before we get to that point, knowing that there is a delay between the community transmission and those people getting sick enough to show up in hospitals.
I've heard anecdotal stories today of 4 people, we won't name them, affiliated with Lab Central, who ventured out on Mother's Day and now have a positive COVID test. So I was going to ask you, how well has Massachusetts done against the comparative regions in the past? Maybe this is a good question also for Rick. I mean, you guys are studying population level health and interventions. How, like Boston got an early warning, I think, through the Biogen outbreak, and at least it was, we were aware of things. And how do you see the measures that we had in Massachusetts? Did you feel they were the right ones so far? Have they helped us? And what's the scope of the effect, do you think? You're on mute.
Rick, I think you're still on mute.
Yeah, sorry. I mean, I think it's a difficult question to know whether these measures have helped more than if we had done other measures, of course, because we can only evaluate the situation we're in today. The same way, exactly as Jonathan said, the virus doesn't really care what we've done before. All we can say is what situation we're in now, and hope that we learn from the experience of other cities, the do's and don'ts, for example, of other cities, to try to guide what we're doing. What I think, and I think Jonathan would agree, is that if somebody wanted to design, and I am not in any way suggesting that this virus was designed, but if somebody wanted to design a virus that would be difficult to control, this is what you would do. You would have something where the infection occurs weeks before you start getting overwhelmed hospitals and intensive care units. You would also design something where when you reopen the economy, as many states are doing across the US and as Massachusetts is beginning to consider, you would also have the downside that it will take weeks before people might notice that any transgression from the current rules, and even the rules that go into phase 1 or phase 2, what those transgressions lead to. We will not notice in the next 2 or 3 weeks a massive increase in cases, unlike what you might see if you were actually testing everybody. We're just going to try to see, are there more patients being hospitalized? Are there more patients in ICU? And are there more deaths? But as Jonathan said, that will take, if that happens, which we hope not, that will take several weeks, during which time people's behaviors, if they're negative, will be reinforced by the fact that they're not reading anywhere that there's an increase in cases. So unfortunately, I think what we have to live with is the reality that we are always fighting something that has occurred several weeks ago. And it hurts us when we try to figure out where we are today. And it also hurts us if we try to explain to the general population that even if it looks like the number of cases is declining currently, if we start changing our behavior, the number of cases could be really dramatically increased, but 3 to 4 weeks from now, and that will not have changed people's behavior in time.
You're implying that the phased reopening will lead to more spread of the virus, which makes sense because everybody is not yet immune. In fact, numbers that I saw estimate maybe 10% or so of people in Massachusetts having antibodies. So there's still 90% to go, if you will. And how will we see and how long do we have to wait until we see the effect of the current reopening visible, and to tell us whether we've done the right thing or we've gone too far or we can open a little bit further? When do you now, if this week is the first week that people go to, in fact, churches are now open, right? And certain businesses that used to be non-essential businesses are now open. When do we expect to see those effects measurable? Maybe Rick, take this.
I mean, I think if you look at the governor's plans, there's a minimum of 3 weeks between each phase, as I heard him yesterday. I think it's good that there's a minimum. I don't know, honestly, maybe Jonathan has a better idea. I think that's a bare minimum because it really depends on what you're measuring. And if we do have the ability to start looking very carefully at a large amount of testing to tell us what is the background rate of positivity in the community, then I think if you felt comfortable in 3 weeks that it hasn't really increased significantly, that might be a good time to slowly stage up a second phase and monitor to see what intervention you have allowed, what new movement you have allowed that is resulting, if it does, in an increase in cases. We open churches. If we suddenly see in 3 to 4 weeks that there's a lot of outbreaks associated with the church, unfortunately for churchgoers, that will signify that is potentially a hotspot and maybe something to reconsider. Same, France, for example, is opening up schools and now is trying to think about maybe they should close schools down again because they're seeing some fluctuations. In a way, it's empirical. People like Jonathan will model this, which I think will be very useful, try to understand which interventions, which relaxing of what activity has resulted in an outbreak, for example. Those are very useful data points that will help us determine, in addition to the background rate of positivity, how quickly we can move and which activities should be allowed and which should really be restricted until we have either a drug that can mitigate symptoms or hopefully in the not too distant future, a vaccine that can wipe this thing off the surface of the earth.
We'll come to talking about a vaccine. I think that's a hugely important topic and interesting for all of us. Jonathan, I've seen that your group published an interesting study recently about the disease spreading in different geographic regions in New York City. Could you walk us through sort of the highlights of your findings and what can we learn from that? What do they mean?
Yes. So to clarify, one thing, it's a preprint, so it has not yet been peer reviewed. This is a manuscript that we made available online with the thinking that the findings were, even if not yet peer reviewed, something that would be of broad interest. And then also, as has happened with many manuscripts now in this era of COVID-19, there's an opportunity to get feedback as well to make sure that it's the highest quality science. So,
and I want to say I really appreciate you qualifying this because it's so important. We see so many preprints now of people making claims and publishing so-called findings that are then adopted by people around the world with no scientific basis. So thank you for that disclaimer.
Yes, and in fact, some people who have taken to press release for science even without any data. And when we get to the discussion about the vaccine and the progress with the Moderna vaccine, I would also point out that right now the only information that I've seen has been through a press release. This question also, I think, touches on what you mentioned earlier about findings about the seroprevalence in Boston, that there's nuance around that 10% value. And that nuance has to do with the fraction of the population that's been tested, which communities have been tested, and how that testing was done, right? What we want is a random representational survey to really get a sense of what the seroprevalence is in a population. There are different ways to design these surveys with which to start to interpret what the overall prevalence is. And I think one of the findings from again, not yet scientifically reported, but initial reports from the Mass General group that did a lot of this testing had to do with the geographic heterogeneity or neighborhood-based heterogeneity in seroprevalence. So they saw, for example, lower levels of seroprevalence in Dorchester and higher levels in East Boston. That echoes what we found in terms of prevalence in New York City. So starting at the end of March, hospitals in New York City began a program of universally screening pregnant women who presented for delivery. So every pregnant woman who was admitted to deliver a baby was swabbed to test for virus. So are they virus positive? Not serologically positive, but virus positive, so using PCR. We collaborated with a number of hospitals in the New York City area and looked at data from the end of March through April. So around 5 weeks of data, around 1,700 women. And we looked at what the rates of positivity, again, virus positivity were. And we looked at the zip codes, or the boroughs from which these women, or where they lived. And what we found was that there was substantial heterogeneity, substantial variation by borough. So the lowest prevalence was in Manhattan, and that was, we estimated, around 10%. And then in the Bronx and in sections of Queens, we saw 25% and higher, right? So significant variation. Their confidence intervals, you can look at the manuscript as well to see just how wide some of these confidence intervals were, but it looked like there's a substantial difference or a significant difference between at least some of the boroughs. We then, so clearly, this is in keeping with the notion that this pandemic, as we're observing it, is actually composed of hyperlocal epidemics, and it varies by location. One hypothesis that we had was that this variation in prevalence might be predicted by the amount of social distancing that communities are able to engage in. Those that are not able to fully engage in social distancing because perhaps their communities in which you would find essential workers or people who need to continue working for economic reasons might be predicted to have higher prevalence. We used Facebook data that informs on mobility from several million users from the New York City area. And we looked at what is a reflection of commuting mobility. So people who left their boroughs in the morning and then returned in the evening. Using those data, we could then look at the relationship with prevalence by borough. And what we found is that commuting mobility predicted the prevalence very well. So those populations that did not need to continue moving, like in Manhattan, had lower prevalence. Those where there was higher commuting mobility had higher prevalence, and there was a very strong inverse correlation. So this gets back to the idea that social distancing, as we might imagine, limits your exposure to the virus. You don't have as many contacts. The risk of acquisition is lower. And those communities where they have not been able to engage for socioeconomic reasons, for example, or perhaps also because of the household structure and the many people, often intergenerational families living within households, those may be contributors to virus spread. And that may be why we see variation now in particular populations. In Chelsea, for example, the same Mass General group that did the study that you mentioned before found that seroprevalence around 30%, right? So in keeping with some of the higher regions in New York City. And again, getting to this idea that there are some communities that just have not, for economic and other reasons, been able to engage in social distancing and have not been supported to do so by local jurisdictions or governments, municipalities, right? They just haven't had the ability to do so. So I think it's absolutely the case that we have seen very local epidemics. I would add one other point to this, and that is there remains a large susceptible population in many places, right? So again, the virus will spread where there are people who are susceptible. So in Manhattan, even though it was the lowest of the different boroughs, one thing to keep in mind is that many of the wealthiest Manhattanites left the city, right? There's actually a substantial decrease in the population of Manhattan as people fled to other locations. When they come back, the overall population seroprevalence will decline, right? It's actually, they're going to flood Manhattan with susceptible individuals. And so the risk of those populations will change and actually will increase. So it's important to keep in mind that the dynamics of infections aren't, what we've seen isn't, first of all, the only thing we will see. It will change as our behavior change and as our locations change too.
So you only studied prevalence. You didn't really study the severity of clinical cases, is that right?
That's correct. This
was directly correlated, or do we also see correlation here?
So there was a letter in JAMA that looked at hospitalization and death rate by borough. And it reflected the same variation in prevalence. In fact, one of the questions we had that was a motivating question for our study is, to what extent was that variation by borough a reflection of access to care or underlying prevalence? And the relationship that we observed by prevalence suggests that just the burden of disease is higher. It may also be that access to care contributed to rates of hospitalization and death by neighborhoods, but what we observed was also consistent with the variation in prevalence.
As we think about populations exposed, and you're slicing very finely now geographically, right? But then with the reopening, there'll be certain groups that now go out that weren't exposed previously. And of course, as a parent of young children, I care a lot about sending them back to school ASAP. And I'm sure that many of our viewers are feeling the same. At the same time, that is clearly a risk. And there's this new syndrome that's called multi-organ inflammatory syndrome, looks like Kawasaki's, reported. And of course, Rick, you work at the Children's Hospital. I'd love to hear your take on this and see, does that inform our thinking about the disease? Let's talk a little bit about this new type of Kawasaki syndrome. What do we know about it so far? Why has it not been reported out of China? Are you seeing these cases pop up in Boston now? Just give us an overview of where we stand on this. I'm sure it's on people's minds.
Sure, and it is a big difference from the last time I had the pleasure of being on your panel, because at that time, as you recall, we were under the hope and the expectation that this disease would not be as severe in children as it is in adults. I think, to reassure everybody who have children and who care about children, of course, it's still true that this disease is predominantly not a disease of children, but there has been the emergence of this syndrome, initially documented in Europe and then now seen on the eastern seaboard of the United States, so-called, Kawasaki-like. There's also a toxic shock syndrome associated with this. It's a very confusing disorder. There are some characteristics that are very similar to Kawasaki disease, including dilatation of the coronary arteries, which is seen in Kawasaki disease, and also some aspects that are very consistent with what we see with toxic shock syndrome due to staph or strep, for example. So this is just another wrinkle in our understanding of COVID-19, some other aspect of it that was unexpected. I think one thing that is really striking about this disease is that it seems to occur about 3 to 4 weeks after the peak onset of cases occurs in any one city where it has been described. So whether it was in Italy or in London, for example, or recently in Paris, there's a preprint written by colleagues of mine at Necker describing the same phenomenon, where basically after the real number of cases increased in Paris, about 3 to 4 weeks later, they started seeing a number far exceeding by several, dozen-fold more incidents of Kawasaki disease in a 2-week period than they had seen in the previous couple of years. And it's, again, a couple weeks after you would have expected an acute viral illness to present, suggesting that this might have characteristics of a post-viral inflammatory response syndrome to this new virus. It's fascinating in a scary way, but it's fascinating for those of us who have been treating and taking care of patients with Kawasaki disease for years, because it's a syndrome identified originally in Japan with no etiology. People have hypothesized all sorts of bacteria and viruses and combinations of both. Some people have even thought it could be a mold. All sorts of hypotheses have been generated, but honestly, no pathogen has truly ever been identified as causative of Kawasaki. There are certainly case reports of individuals who come down with one disease and then a few weeks later they come down with Kawasaki. And I think those examples are now, in the context of COVID-19 related Kawasaki syndrome, teaching us a lot, not only about COVID, but also about Kawasaki disease, that it is perhaps a disease, post-infectious disease, in which some individuals, obviously a minority of the population, some individuals are susceptible to this type of hyperinflammatory syndrome characterized by fever, by rash, by lymph node swelling, by a desquamation, for example, of their fingertips, and these coronary artery aneurysms that might really be the consequence of a bizarre response to either a common infection pre-COVID or to COVID-19 now as a new pathogen. The children who have had this syndrome in Europe and in the United States have by and large responded pretty well to therapy, which has included the administration of intravenous gamma globulin, as we do for Kawasaki disease, and also, in some cases, the administration of anti-inflammatories such as steroids. That does not tell us whether that is a causative relationship, but we believe that what worked for Kawasaki has a good chance of working with COVID, and therefore it's a very reasonable thing to do. There have been, unfortunately, some children who have died of this syndrome. So it is, of course, very scary. And anybody who has a child who has symptoms suggestive of Kawasaki disease, pre or post-COVID, should, of course, immediately seek medical attention.
Rick, do you know if there's a correlation? We hear that most pediatric infections with COVID have an asymptomatic or very, very mild clinical presentation. Now, is there any data on these post-COVID immunological responses? Are they in asymptomatic kids, or are they in kids who've actually shown the clinical signs of COVID?
Yeah, it's a great question, Johannes. Most of these children, to my reading, did not have signs and symptoms that prior to this that would have said, oh, this child has COVID. I read one, so in other words, it appears that their COVID diagnosis, which is typically made either by PCR or by serology, that's how that association was identified. The majority of children, particularly in the Parisian study, all but 2 out of, I think, 18 kids that were reported, all but 2 had some evidence of COVID exposure or virus. So the majority have that. have some evidence of COVID, but not the symptoms. There was one child in the French study that I reviewed that basically had anosmia that developed. So basically the inability to smell, which is now thought to be a sign of potential COVID-19, that occurred, I think, the day of or the day just prior to hospitalization for Kawasaki syndrome. But by and large, I think it's fair to make the statement that this is not an acute presentation of COVID-19. It seems to be much more likely to be a post-infectious or post-acute, because most of these kids have antibodies, which we don't believe emerge until the first or second week after infection.
Talking about immunity and antibodies, there's of course this hope that as we eventually may have a vaccine, or as people have been through the disease, they will be protected against a second infection. I know that there's sort of varying degrees of confidence. Where do you see that fall right now? Is there any good data that says people who've had a coronavirus and been through it, either symptomatic or asymptomatic, are protected of a second infection? Maybe Rick, this is squarely down your area.
I think there's hope, of course, based on what we know about other viruses that are related. In the case of SARS, as you know, there's been the documentation of neutralizing antibodies that have persisted for 1 to 2 years in individuals who were infected. But of course, there was no second wave of SARS to prove that those individuals could not get SARS again. So we're sort of limited. Seasonal coronaviruses, it appears that you do get some temporary immunity to the specific strain that you've been infected with, although it's not very long lasting. I think the best news, and Jonathan may want to comment on this too, the best news that we have heard recently came from a recent paper in Cell that described the antibody as well as the cellular immune response of individuals who recovered from SARS-CoV-2 infection. And it's pretty clear that those individuals not only develop antibody responses, which is promising, but also a pretty broad range of CD4 and in some cases CD8 responses. So their response to the virus is broad, and one can hope that that type of response, which is involving not just antibody, but also T cells, could translate into either partial or more complete longer-term immunity against this virus. It is very important, and we'll get to it perhaps if your viewers have any questions about vaccines. It's important to understand whether antibodies, T cells, both, which one more than the other, is important for long-term immunity, because that will, of course, inform which of the over 100 vaccine strategies that are ongoing right now, including at least 6 that are in phase 1 or 2 clinical trials, which ones of those vaccines should really be viewed as the most promising and be pursued most aggressively.
Jonathan, what do you think? Where do we stand? Of course, Boston famously has Moderna and other companies working hard to get the first vaccine out. And are we close? We hear positive signals being sent by the company and by politicians that we have a light at the end of the tunnel, and that we should hope for a vaccine to come even before the end of this year, which would be great. Do you have any insight there as to whether this is justified optimism or not, and how can we brace for disappointment, or what else is in the pipeline to help us if the first shot doesn't hit the goal?
I think it is worth being cautious and skeptical. We have many ongoing vaccine programs that should give us sources of hope, even if the first candidates are not as successful as we would like. Right now, I think the data that we have, as we talked about very briefly at the beginning, is quite limited. I don't think people have seen a scientific report just the press release from Moderna. So I would say the jury is still out, certainly even on this phase 1 effort, and particularly as we await phase 2 and phase 3, which are really going to be the crucible through which any vaccine, any effective vaccine has to pass. So I would say, the first steps were necessary, but certainly far from sufficient to get us to a point of being able to protect the population through an effective vaccine. So we've got a while to go. And I still think that this idea of end of 2020 or beginning of 2021 for our vaccine is overly ambitious and sets expectations way too high, not only for the creation of an effective vaccine, but the ability to manufacture and distribute it. I think that we're looking at a much longer time period to be able to generate the number of doses that we would need to really protect the population, even if we were to show that a vaccine has effectiveness. And again, I'm not sure that we can do it within that time period, but even if we could, to really get it up and produced at scale, I think is going to be a huge challenge. I'd reiterate one of the things that Rick said as well, that therapeutics in the meantime have to be another area in which we're putting a huge investment. An effective oral drug that can reduce the likelihood of severe symptoms, it can treat or cure these infections, would be a huge benefit and really another off-ramp, and potentially even a much closer off-ramp than that afforded by vaccines.
Yeah, we are coming up already towards the end of our discussion. I have a bunch of questions here on my screen that Megan thankfully is channeling to us from the audience. And so let me pick this one. That I think that's a good one for you, Rick. It's very specific on the vaccine. Please apologize if I put you on the spot. It says, Moderna says 8 patients in their phase 1 trial had neutralizing antibodies and 37 had binding antibodies. How effective are binding antibodies historically in other vaccines, and do we see this as a meaningful outcome so far?
Well, maybe I'll try. I know we want to always end these on a very positive note. So it's much better to find some antibody binding to the antigen than if you hadn't. So that's good. And it's also nice to find some neutralizing ability, and that's also good. But to echo what my friend Jonathan has said, you need to know, did they only look at 8? Did they look at all of them and only 8 had neutralizing antibody? And what were the titers? If the titers of neutralization were through the roof, that would be promising. If they were barely detectable, but statistically different from controls, or from pre-sera, that would be maybe less exciting. I think it's very important, and the questioner is absolutely right. We have to sort of look at these data and say, it's good enough. We hope that that's what the FDA has seen, and they said it's good enough to proceed to phase 2, recognizing that a phase 1 is really just a trial of safety and tolerability. There was one individual, as you know, at a sort of grade 3 response. We want to make sure that that doesn't, translate into much worse responses in a greater number of recipients. But the phase 2 is really, we're going to start seeing what the scope and the breadth of the immune response is. Certainly better than if they had seen nothing. But I think it's too early to say that these are encouraging or very promising results, because, as you mentioned, there are examples of vaccines that generate non-neutralizing antibodies that just bind but don't neutralize virus. And those can sometimes be either ineffective or sometimes actually worsening in an antibody enhancing fashion, which we really would not want to see with a disease that can affect such a wide range of the population. So
we still have to wait really for these phase 2 and phase 3 studies to come out. Here's a question for Jonathan that goes, quarantine fatigue is real. Even though the best way to eliminate the virus is to lock down entirely, will we now have to compromise on the middle of the road solution, and how might that look? And especially based on your experience of studying various populations, what do you see as effective mitigation that's also economically feasible?
Right. So I would say yes. Community quarantine has successfully, it seems, here flattened the curve. It does not eliminate the virus. I want to underscore that point. It reduces transmission, but it does not eliminate. And with a susceptible population, you remain again at risk for resurgence once the virus is reintroduced or starts to spread more in the population. You know, when originally we went into the lockdown, the hope was that we could use the time in which we were flattening the curve not only to diminish the amount of disease and help maintain healthcare infrastructure, but also to study which parts of mitigation efforts were most successful. In some ways, using the natural experiments across states and municipalities where different levels of quarantine were enacted to help understand what's effective. You know, do we have to, just get rid of the meetings of 50 people or more, or is it 25 or more, or 10 or more, or is it churches, or is it schools? All of these remain questions that I don't think we have good answers for as yet. And my expectation is that we're basically going to stumble our way through this, trying various types of now perhaps less blunt community quarantine efforts, or efforts less than or different from this blunt community quarantine, and see what effect those have, because it is true. Not only is quarantine fatigue real, but the economic consequences are huge. So we'll see.
We only have a few minutes left to wrap up, but here's one that I know Rick is going to enjoy commenting. It's a political one, so be warned. What influence are anti-vaxxers going to have in the US as we roll out this vaccine, and how are we going to change the minds of this very influential group? Or might this health crisis change their mind naturally?
No, I don't think so. And I think actually it's a very good question. And I think that that's the reason many of us, Jonathan and myself, and many of our friends and colleagues feel very uncomfortable with the language that is coming out of the administration about how quickly we're going to get a vaccine, and how this is going to, this is simple. We already have candidates. We already know that this is going to work, because you could imagine a vaccine like this being pushed too fast, having a series of important and maybe even catastrophic side effects. And that will unfortunately fuel anti-vaccine movements in all sorts of other vaccines where those vaccines are clearly life-saving and efficacious. It's important to remember that during the Ebola crisis in West Africa, the biggest infectious disease that followed after the Ebola crisis was finished, was measles. Measles ravaged West Africa after the Ebola crisis had basically dwindled. And we do not want to see anybody taking advantage of the difficulties in developing a COVID vaccine in the US or in Europe or worldwide as further fuel to unfortunately try to create the impression that vaccines, as they are licensed and go through the normal process, are unsafe. We know that vaccines have side effects. It's conceivable that even any vaccine against COVID will have a balance of benefits and potentially some side effects that individuals will have to consider whether they want to take that risk in obtaining a vaccine. But what we cannot do, and what we should not do, is basically take bad science under the fact that we are in the midst of a pandemic, to take bad science and push something that could hurt children, adults, elderly adults in the midst of this pandemic.
I think that's a great wrap up, and I want to end our today's panel on this impassioned plea that to not rush the vaccine at the expense of safety and efficacy. I think we'll all benefit from that. I want to say thank you to Jonathan and Rick for joining me on this panel. I had a lot of fun. I'm sure audience took a lot of meaningful lessons from this. I hope you had a good time being on this panel with us. I want to also invite you and the audience to join us again for our next and upcoming panel on June the 2nd, where we're going to talk about learnings from phase 1, learnings from the year opening in phase 1 and practical implications of opening. So until then, thank you for joining us and see you in 2 weeks. Bye-bye.